Hello.
Okay, can you hear me?
Yes, we can hear you.
So the next case for EUS that I'm going to present is of a 50-year-old male who is known case of diabetes. He has abdominal pain and loss of appetite for about a month. His CT scan shows pancreas that appear heterogeneous and swollen. Multiple areas of necrosis with parenchymal and ductal calcification are seen within it. An irregular, heterogeneously enhanced necrotic mass measuring about 4 into 3 into 2 centimeters is seen in the region of neck and body of the pancreas. It is closely abutting the pyloric antrum with loss of the fat planes. It is encasing the hepatic and splenic branches of the celiac artery. It is also involving the pancreatic duct, resulting in dilatation of the pancreatic duct in the region of body and tail. There is nodularity and thickening of the surrounding omentum, and there is a filling defect in the main portal vein extending up to the portosplenic confluence and proximal splenic vein representing thrombosis, and also there is cavernous transformation of the portal vein. So now we are proceeding with the EUS, and we'll be trying to do FNB.
What is the differential diagnosis? Why are we doing it?
It is a mass in the head of the pancreas.
Okay, thank you.
Thank you.
Kalsab, can you hear us?
Yes, I can hear you. I need a mic.
While you're getting ready, is it possible to have a look at the CT scan? We cannot hear you yet, sir.
Arya,
Yes,
can you hear me?
Yes, now I can hear.
So we asked them for the CT images to be sent to you. So hopefully you'll get those.
Okay, right, fine. Thank you very much.
Okay.
But you've heard the history, with a history
No.
like this, other than that we are doing the workshop. What is your differential diagnosis in a patient like this?
I did not honestly hear the whole history. The only thing is
It's a mass in the neck of the pancreas, roughly about 4 centimeter, encasing the celiac artery, and then it's involving the portal vein as
portal
well.
vein, and there was
So
some
we know
filling defect in portal vein too.
Yeah.
So okay.
So PVT with the cavernous transformation. So in all probability, adenocarcinoma.
So yeah, I think you can go through that. Obviously, that's especially number one. Whenever you think about the mass, you think about likely malignancy, and then there are different type of malignancies, and then you have to take a think about the benign process, which can look as a mass as well. So malignancy, I'll keep those to the side. With regard to benign process, whenever they say like possible mass, you have to think about the chronic pancreatitis. Is it an inflammatory mass? Is it autoimmune pancreatitis? Or is it some other extra pancreatic malignancy or a mass which might be involving a pancreas and looking like a pancreatic mass? Okay. क्या हो रहा है? Usually होनी चाहिए, but इनके पास है नहीं. हाँ जी. तो वो जो है ना रीमा जो है ना वो उसको होल्ड करेगी.
So Khalid, if it's an extra pancreatic mass involving the pancreas,
पहुंचा दें. उनको मैंने कहा है कि आपको पहुंचा दें. ठीक है?
Khalid,
जी.
if it's an extra pancreatic mass involving the pancreas,
जी जी. Main
which
one
is
is
the
the
best modality which is going to help?
metastatic pancreas, a metastatic lesion. That's one thing. Second thing is a duodenal malignancy, or entity which is we call a grooves pancreatitis. That sometimes even though it causes cystic changes in the duodenal wall, but that can be involving head of the pancreas as well. That's usually is an inflammatory mass. So by that
It's
I
a
meant
neck
was
mass. Khalid, it's a neck mass.
this is, I'm just talking about the
Okay,
head.
in general,
Yeah, yeah,
in general.
So general I'm talking about. And I thought it was head, by the way. So it's a neck mass. And usually the neck mass, also if we are looking at, if we're talking about the portal vein thrombosis and neck head, sometimes the extension is there into the head as well. Okay. ठीक है? आप इधर आ जाओ थोड़ा। तो तो एक मिनट इसको थोड़ा सा ऐसा करें, ठीक है? एक मिनट ज़रा बाहर निकालें इसको थोड़ा, ठीक है? तो if you hold it from here, you don't have much space क्योंकि नीपी, okay, so always try to hold it at 25, 23, 22, it should be after 20, ठीक है? तो इसको अगर आप स्कोप की मूवमेंट देखें ना, स्कोप को ऐसे रखें, big wheel towards you, you see that, like how it's moving, ठीक है? So you go in above the tongue, it will hit the back of the throat, and when that does, then you gently, very gently move and then gently rotate with, very gently, okay? And you can see that here on the endoscopic view. And when you get to the back, what I do is like a gentle rotate, gentle. You say if you rotate it like that, it will go through, okay? They usually end up swallowing it. So very gentle, very gentle. When you go through the esophagus, you have to slow down. Okay, इसको इधर रखो। यार ये एंडस्का
वो सामने आ रहा है।
वो तो है EUS। इसकी लाइट ज़रा कम कर देना। Okay.
अच्छा ये
आपने स्लो डाउन होना है, ठीक है? I think you're a little bit too moving too fast. ये आधी लाइट नहीं होगी? हाँ, एक करो ज़रा कम। नहीं इधर से वी आर गोना गो सिस्टमैटिकली, ठीक है? ये नहीं है कि लिवर नज़र आ गया तो वो डन। सो हाँ, जी जंक्शन, ठीक है? तो हियर शो मी द एंडोस्कोपिक, फॉरगेट अबाउट दैट, यू डोंट हैव दैट स्क्रीन राइट नाउ, ओके? सो लुक एट द एंडोस्कोपिक इमेज, ठीक है? थोड़ा स्टमक के अंदर जाएं, यू आर नॉट एट द जी जंक्शन येट, ठीक है? रहने दो, ठीक है, कोई बात नहीं। यहाँ पे ठीक है, अब आपने स्कोप को सीधा रखना है एंड मूव द व्हील्स डाउनवर्ड्स, रोटेट करें। नहीं दिस इज डाउनवर्ड्स मूवमेंट, ओके? इधर देखें ज़रा, जी जंक्शन पे दोबारा दिखाएं मुझे एंड
ऐसे करके
हाँ
जी जंक्शन देखिए ना।
हाँ जी,
ठीक है।
उसको भूल जाएं बिल्कुल,
No, no, I'm not looking at this.
ठीक है?
Yeah.
ठीक है, और स्टमक में जाएं थोड़ा सा, थोड़ा सा, ओके, यहाँ पे रुक जाए, ठीक है? अब वो व्हील्स को नीचे मूव करें, you see that? Okay, stop there. Now go towards that. Just go straight.
Okay.
Go straight. ठीक है, अब यहाँ पे रुक जाए, suction and big wheel towards you. Suction and big wheel towards you.
Yeah.
नहीं चलते जाओ, उसको आपने
Should
compress
I keep
करना।
moving the
No,
scope?
ठीक है? What I mean by चलते जाएं कि suction,
Keep doing,
suction,
okay.
suction, keep suctioning.
Yeah.
Okay. Well, pull the scope back a little bit. Now big wheel towards you.
Yeah.
Big wheel towards you, and you got straight to the left lobe of the liver, ठीक है? G junction, you stop at there, move the wheels a little bit downwards, okay? That will show you the opposite wall of the stomach. You go there, that's 4-5 centimeter below the G junction. Big wheel towards you, suction all that, everything out, fluid and air. And then you rotate a little bit to the right. That gives you left lobe of the liver, ठीक है? Left lobe of the liver, now most of that is to the right side, just a little bit is to the left side. What we're going to do is 2/3 of that needs to come to the left side of the screen, 1/3 to the right. So what the way pull the scope back. You see that? Big wheel towards you a little bit? We need to get rid of that air. So that the way you're going to do that is by suctioning and big wheel towards you, ठीक है? Now big wheel towards you, okay. A little bit towards you further. A little bit big wheel towards you. Just a little bit. Okay. Now it's at 180. Okay. So now if you bring the scope, like you see that how the numbers look here, numbers are moving like that. They need to move like that. Okay. So we're going to bring from 180 to 90. Keep coming back. Keep coming. Keep coming. I don't see the movement of the scope. Okay. Now it's moving.
Yeah.
Okay. Keep going. Keep going.
That was IVC?
That was IVC. ठीक है? Keep going. Big wheel towards you a little bit. Keep going to the right.
So
right
this
there.
is
ठीक
it,
है? Your wheel is way too much up towards you, big wheel. So release it a little bit, okay, while maintaining the, okay, that's good. थोड़ा सा और दे दो आप. Okay, so when you get to that,
तो खालिद भाई इस वक्त मैं यूँ आई हूँ तो आया aorta
हाँ जी,
like
थोड़ा सा आपके मूवमेंट पूरी जो आप यहाँ पे कर रही थी ना, वो ट्रांसमिट नहीं हो रही थी. So that needs to be transmitted. That's just this movement. ठीक है? अगर if it fully transmits towards the end of the transducer, you won't have to do that much. ठीक है? So that will come with the experience. So it's not a problem. ठीक है? अब now when you get the aorta, ठीक है?
So
Gently.
if I have to push the scope further, do I have to come closer to the patient?
No, like whatever
क्योंकि
space you
मुझे-
need to,
हाँ,
yeah, you can
I
come
need to
closer,
some-
yeah.
हाँ,
ठीक है?
like I need to
Yeah.
push
And just goal is to keep and maintain
celiac,
that
I can
position.
see the celiac,
ठीक?
yeah.
You see the celiac,
Yeah, I
right?
can
Okay.
see
Sometimes the scope gets hung up on hiatal hernia or the gastric folds. In that case, you need to move the scope back and get that up. But I think we are okay here. So we'll follow the celiac. You see that celiac
Yes,
right
yes,
there?
in a
And you see
SMA
a
as well.
SMA too.
Yeah.
Oh, perfect, okay.
So
You see
I-
a celiac, SMA. We're going to just follow the celiac, okay? Just and yeah, gently release the wheel a little bit, so that will take you to the gas right there, okay? So let's bring that back. Good. You see here, there's a branch coming off here. This one, that's
Yeah,
coming
left
off the
gastric?
celiac. That's a left
Yeah.
gastric, right there. You see?
Yeah.
Okay. We're gonna forget about that. We will just follow the
So
main
I have
trunk. Okay. Gently and rotate a little bit to the left.
Okay.
A little bit to the left. Okay. Now release the wheel a little bit. Further, 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 further. Release the wheel further.
Yeah. It's released. And push.
So, yeah, this is a.
Oh. Oh. We have stones here. Yeah.
Yeah, we can see that quite a bit of stones in there. So that's a really feature of a chronic pancreatitis. Having said that, I just don't like the way the tissue looks like in here. So we'll work on that in a second.
So Khalid bhai, I can move the scope from here as well without giving any torque. See like this, right?
Yeah.
Okay.
Okay. So the goal is do whatever it takes to do the exam. Okay.
Yeah.
Okay. From here, I don't see the duct really well. I think it's all stones there. So let's rotate the scope a little bit to the left.
मैं
If
इसको
you
यहाँ से
move
करती
back,
हूँ, okay.
yeah.
So I can rotate from here and
Keep going
go
to the,
there.
yeah. So it's all,
Yeah.
yeah. Now pancreas is disappearing there. So what you need to do is release the wheel, big wheel away from you, and gently advance the scope. And that will take you back to that, okay? And if it starts moving that way, that means big wheel towards you,
Okay.
and pull the scope back. So we lost it completely. So let's bring that back. And sometimes just the rotation brings it back. So you don't have to go back all the way there.
Okay.
So you just
So I
stay
just need
there.
to-
Yeah, just need to do undo what you did wrong.
Yeah. So I have to release
That's a
it
left
and I have
adrenal,
to
by the way.
push. Okay.
Okay.
So I have to push
Yeah.
and I have to
Push. It's a very. You have to be gentle.
this is-
Pushing is.
Khalid sir, Doppler हटा देंगे?
G.
So this is the pancreas.
Yeah, that's the pancreas, and there's a lot. That's a, like here. There's a fluid collection there. Lot of calcification there, and this is all calcification. I don't see a really mass here, but there was
So there is
another.
a pancreatic duct if it is chronic
I don't see it.
pancreatitis.
I don't see it at all.
Is
नहीं
it
है,
down?
नहीं है, नहीं है. You can't see it.
Yeah.
Okay, so
इधर डॉपलर डालेंगे खाली
G.
सी वो ऊपर वाली डक्ट नहीं है
I have
pancreatic
no
duct?
idea
वो
what
जो
that is. I
anechoic
see.
structure है उसके
It's a
अंदर sludge
necrosis.
layer, yeah.
It's
Yeah,
necrosis.
this one.
Necrosis.
Okay, this
Okay.
is not
It's a
duct.
just. It's not a duct.
Okay.
You don't see a duct. Period. Okay.
ठीक है. Okay, now from here I have to move like this. And
Keep going.
Go,
Because go back a little bit.
go back. Pull.
No. When I say go back means do the opposite of what you were doing. Okay. So no, not too much. let's stay at the pancreas. Okay.
Yeah.
So right here. So what I was wanted to show you is you are talking about this. Okay.
Yeah.
Now rotate to the right a little bit. Big wheel towards you a little bit. What I want to show you, there's another thing like that,
Oh.
which is a totally opposite.
Yeah.
So it cannot be duct, right?
Okay.
Yeah, there's another one right here. So this is all necrosis in there.
Okay. Can you freeze the here? So So this is the sigma sign here, the reverse of S. Can you see? No,
You can make up whatever sign you want.
No, can you see the
This
stones
one?
within the, yeah, within
These
the
are stones. Usually, they almost always develop in the ductal system. So they could be in the main duct, they could be in the side branches. It's really not a parenchymal stones. ठीक है? Stones almost always develop in the ductal system. So it may be one of the side branch. It could be somewhere here. There could be a portion of the duct here. But the thing is, like, that doesn't matter.
Okay.
It's so much calcification all
Everywhere,
around.
parenchymal and
Yeah, so it doesn't really matter anymore. Okay. So
Achha,
let's go to.
abhi isse
These are you see the collaterals there. A lot of collaterals there.
Yeah.
Okay. So rotate to the left.
We have a note here as well.
Oh, doesn't matter.
one?
This
Okay.
may I think it's a part of the pancreatic. Let's just focus on one thing at a time, because otherwise it's going to be a lot of distraction. Then if we don't focus on the pancreas, we are going to say, what is this? What is that? So let's focus what we are the exam we are doing. Okay? Let's go back to the pancreas.
Here.
So a lot of calcification there. Okay? Okay. And I see a lot of.
On the CT scan that there's encasement of celiac artery as well. Do you see any encasement?
I did not, honestly. If you look at that, you can follow the celiac artery very nicely without any problem. And so I'll have to take another look. But I'll take a look. But what I see now, I did not see really anything.
Yeah, that's
there.
right.
Yeah. So I'll take another look. It may be a SMA may have been involved. But the thing what is happening right now, it's a chronic calcific pancreatitis
Chronic calcific pancreatitis
leading
with
to
a high
necrosis and inflammatory process all around.
Celiac to
And
clear.
the inflammatory process itself can, if it's around the celiac axis or around the celiac trunk, that could be looking like a mass itself surrounding that. Having said that, you have to be really careful not to ignore the CT finding of mass, because chronic calcific pancreatitis or chronic pancreatitis is a risk factor for developing pancreatic cancer. So you have to take a really good look at that, the pancreas. And if I find any area which is hypoechoic and I see a tissue, I am going to go for FNA of that.
अच्छा अब इधर से हल पे ये तो हमने देख लिया, अब उधर जाना है ना हमने दूसरी साइड पे
दूसरी
टेल के लिए स्प्लेनिक हाइलाइट
Yeah, so
तो इसको हम थोड़ा सा बिग व्हील डाउन करेंगे और इसको हम लोग इधर
रिलीज करें थोड़ा बिग व्हील को
Release
थोड़ा सा,
करें,
क्योंकि
ठीक है।
जब पैंक्रियाज आपके व्यू में नहीं है तो
ठीक है,
डजंट, या यू हैव टू कीप द स्ट्रक्चर इन योर व्यू
ठीक है
राइट देयर. ठीक है, ठीक है.
अब
So this is a area of the tail. Big wheel towards you a little bit. Okay.
okay.
Big wheel towards you. ठीक है. And there's so much calcification that you have no idea, and I have no idea what's underneath there.
Yeah.
ठीक है. It's all shadowing there, so we don't really know what's happening over there, and there's no way to find that out. Okay. Cross-sectional imaging, yes, that might tell you, but with this one we
वो
cannot
तो
tell.
वेसल्स आ रही है ना तो ये वो
There
तो
are so
सारे
many
vessels
collaterals
यहाँ
actually. There are collaterals all around there. Okay. ठीक है. Okay. Go to the left. And let's go towards the neck of the pancreas now, because we saw the tail area. Neck is the other way.
उधर जाएंगे,
Okay.
ठीक।
Good, 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 good. Big wheel towards you, because it's a little bit down now. So to approximate, you have to move the
okay,
big wheel
got it.
towards you. Okay. So here.
That's fine.
So this is the area, actually it may be all necrosis, but I'm concerned about that. I'm going to take a look at the head of the pancreas first, and then we may go for FNA here. It may be all inflammatory process, but we need to be more vigilant and make sure that there is nothing there in that area. Okay, let's go towards the duodenal bulb. ठीक है?
ठीक है बिकॉज
Okay.
अच्छा जो करते हैं मैनूवर खालिद पे उस तरफ जाते हैं किडनी और स्प्लीन को देखने के लिए, वो इसी जगह पे कर रहे
हाँ,
हैं
इसी
ना
जगह
हम
पर,
लोग।
बिल्कुल।
तो वो मैंने पूछना था कि वो हम इधर से जा रहे हैं
हाँ,
और
इधर से
we are
जा रहे
moving।
हैं. हाँ, तो
और-
आपका पैंक्रियास उधर जा रहा है, तो उसको कंट्रोल करना है
अच्छा, ठीक है,
पैंक्रियास को.
सेंटर में रखना है,
हाँ,
okay।
सेंटर में रखना है. तो
ठीक
फिर
है, और
उसके
उसके
बाद
बाद फिर?
करते जाएं, राइट चलते जाएं जब तक पैंक्रियास ख़त्म नहीं होता, आपने चलते जाना है. ठीक है.
ओके दिस इज द किडनी
हाँ, हाँ.
और मैं तो मुड़ ही गई हूँ पीछे स्प्लीन आते वक्त तो मैं
I don't see
बैक
any.
हो गया
Yeah, I did not see the spleen yet.
हाँ तो कितना को मुड़ना होता है कि तो मैं
No, I
opposite
don't
ही
think
हो
it's
गई हूँ
wrong. नहीं, let
नहीं
me see.
मतलब मैं
एक मिनट
इधर ही
दिखाएं
हो गई
जरा.
हूँ ना ये अभी तक ये
No, no,
अब से-
your transducer may not be in the right place. एक मिनट दिखाएं जरा. Okay, let me see. Okay.
इतना भी है ना वो ओवर होके मुड़ना होता है ज़्यादा
नहीं, हाँ. You see that the celiac trunk is pretty much clear right
Yes,
there.
we can see that. It's very
Yeah,
clear.
it's a very clear really, and right where the bifurcation of the celiac trunk into hepatic and splenic is, that's where the mass is. So right there is the mass, calcifications, inflammation, everything. You see, ये देख रहे हैं ना कि कहाँ पे मैं उसको mass को उसको मैं हिलने नहीं दे रहा वहाँ पे, ठीक है? एक ही जगह पे वो है, और अगर वो हिलने की कोशिश करता है फिर मैं scope को जो है ना rotate कर रहा हूँ, and or just whatever made it go away, I do the opposite of that, ठीक है? And here there is so much calcification here. The kidney is at the bottom. You see that, and right there, and there is a distal this is it's going right into the tail area. This is all tail area. So I'm going to put a Doppler here, and this may be the duct right here. You see this?
Yeah.
But it's in the tail area, and it's all blocked by the stones. So that's why it's dilated. So from here, you see the spleen right now? Spleen.
हाँ वो ये
Okay. मैं पूरा नहीं मुड़ना पड़ा, ठीक है?
आधी
So
मुड़ के भी आ रही है
आधी मुड़ के भी नहीं है, मुड़ने की जरूरत ही नहीं है, क्योंकि मेरी बैक जो है ना बिल्कुल स्ट्रेट है. अगर स्कोप जो है, इफ इट्स नॉट स्ट्रेट आई जस्ट स्टेप बैक, ओके. लेकिन जब मैंने स्कोप को पुश करना है तो आई मूव फॉरवर्ड. सो यू हैव टू कीप एक्सरसाइजिंग अ लिटिल बिट. राइट देयर इज द स्प्लीन, ठीक है. This is the, I'm gonna, now I have to move the scope in a little bit, so I'll move it in like this and rotate the scope too at the same time. You see the left kidney right there. You still see the that mass right there. Okay. देख रहे हैं सारी चीजें उसी तरह मैं scope को फिर मेरे I'm just looking at the screen. I'm not pushing it too hard or doing nothing hard with the scope itself, but I'm trying to keep my landmark here is the pancreas, which I don't want to miss, right? So I'm keeping that underneath the transducer. That's the goal, between 4 and 8, or between 5 or 7, or at 6 o'clock position. So that's the best. Whatever you want to examine needs to be staying in that.
अगर स्प्लीन की तरफ जाएंगे तो तब भी पैंक्रियाज आता रहेगा क्या?
आता रहेगा जब तक आपकी, हाँ, तो वो पूरा पैंक्रियाज ही है ना, ठीक है. आपने बॉडी नेक से शुरू किया है, बॉडी है, फिर उसके बाद डिस्टल बॉडी है, फिर टेल है. At the tail of the pancreas is stuck between the spleen and the left kidney. ठीक है?
So मतलब keep the pancreas in view.
Yeah, keep the pancreas in the view because that's your landmark. Okay. यार एक काम करें, ज़रा मुझे एक नीडल दे दें FNB 22. मैं एक दफ़ा एक पास कर लूँ. So it could be all inflammatory process, but I just don't like the way this looks. Okay.
Khalid, do you think that there's some neoplastic process in
I
this?
am very worried about that, to be honest with
Yes,
you.
it is
Yeah,
quite
because
irregular.
it's like a little more organized here, hypoequic organized. So, and it could be an inflammatory process, but without FNA, I cannot tell you that there is nothing hiding in there.
अच्छा ये सारा का सारा हेड ही बड़ा
No, this is not, bada heterogeneous, but you see, here, this is I'm calling more chronic pancreatitis because it's little atrophied and it's all calcification there. This is all calcification there, okay? And these are some areas of necrosis. I can appreciate that very easily कि यहाँ पे जो है ना ये necrosis है. This is not the mass, okay? But look at the difference between that, because the necrosis, when you see those whitish lines in there, and it feels like there may be some fluid in there, and it's like a little more like a vein, like the blood cell. When you look at the IVC, the way that flows around, so that gives a impression of that. But here, when you look at this area is more organized tissue,
Yeah.
right? Yeah. So that's what which bothers me here. Okay.
अच्छा जो
not
mass
from the
के around
necrosis. They
area
will
है
necrotic
वो
area. They
देखें
will take the
Yeah,
bypass
that's a
of this area.
it's a very irregular, ठीक है ना
हाँ,
एक
उसके
तो
margins तो बहुत
but
irregular
very
लेकिन जो
irregular
हाँ,
and
लेकिन जो adjacent area है is it clear?
what do you mean adjacent area is
हाँ,
clear?
adjacent area का मतलब जो mass की outline के बाहर वाला जितना भी area हमें नजर आ रहा है
It's all fat.
yeah
all
is
fat.
clear. Fat
Yes.
is clear.
Yeah, fat looks clear. So here you see that
Yeah.
they are facing towards me.
अब आप उसको
ठीक
rotate
इसको
करके
rotate
उठाएं।
करेंगे
हाँ,
तो 75 and right there.
okay.
ठीक है? So if they are facing me and then it's usually is a 75% circumference and then it gets to you. ठीक है? Right there. This is what I don't like. ठीक है? So I can put a Doppler to make sure there's no major blood vessel up there, right in this area. I don't see anything major. It's going to be a little bit. Remember that FNA needle? That's a sharp needle. It has only one edge. The core needle, especially this core needle, has 3 cutting edges. So when you put a single edge through the stomach, through the gastric wall, it's easy for that to go through. This, with the 3 cutting edges, literally have to dig a hole pretty much. And you're boring through the wall. That's what it is. So this one is going to be a little harder to get that through the gastric wall. Gastric wall is very thick and very hard and very strong. So the way you overcome that is make sure your needle is properly locked. You bring that needle out a little bit. You see that? I'm going to use a little bit elevator right there. I will push the scope a little bit right there to approximate. So isko hold karna yahan pe scope ko zara bit. So I bring that needle out. I intend or make a tenting of the wall first with the needle before I go in. If I go in slowly like this, I'm just pushing it away. So I'm gonna, after I make a tenting or indentation of the wall, it's gonna, you look at my hands, what I'm gonna do is, I'm gonna do a really quick but controlled stab. You see that? I don't know if you even notice that or not, but I'm into the lesion. And it's a very controlled, I know how long that lesion is, so I'm not getting through and through either. Okay.
अच्छा after puncturing the gastric wall खाने से आपने stab किया ना?
Yeah,
पहले
no,
puncture किया?
नहीं puncture नहीं किया, मैंने सिर्फ उसको anchor किया है,
ठीक है
क्योंकि you cannot puncture the gastric wall just by doing this. So it's like it has 3 cutting edges. You sit on the wall, those edges go into the mucosa, so you anchored yourself. The hardest part to get through is the muscularis propria, and that really needs a quick stabbing, and especially with this needle. Okay?
ठीक है
रीमा कमज़ोर हो गया, तुम ज़रा इसको ज़ोर से पकड़ो.
needle आ रही है नज़र बहुत अच्छी
और देखें मैं सिर्फ एक जगह पे एक ही बारी जा रहा हूँ, ठीक है? So I did 4, so I'll take it out and I'll give the needle to Wasim. परेशान लग रहे हो अच्छा and it may be a lot of inflammation, necrosis in that area. So it was really very easy and soft to go through the mass itself. So I'm just concerned it may be all necrosis. But let's go to the duodenal bulb, okay? And then we will come back and do another pass there. So endoscopically, pull it back. When you don't see anything endoscopically, you always pull back, okay? I mean, inflate karna padega. Inflate. And the camera on EUS scope is at 45 angle, so just keep that in mind. Big wheel towards you.
Yeah.
Good job. Excellent. उसके wheels unlocked है ना? ठीक है. Fine. So
So
go
open
in.
हो जाए
Yeah.
तो
No, open है. कोई मसला नहीं. Yeah, this is open. So when you see the opening even a little bit, that's open. So come back a little bit. So you have to angle that. Yeah.
इसको
Okay.
नीचे लेकर आना होता
हाँ
है
जी,
ना?
ज़्यादा नहीं.
ठीक है
Still keep in view a little bit that it's different from ERCP scope. So it's no, एक मिनट. Come back. Go in a little bit. Follow that. Okay. again, go in, stop there, okay? It's trying to run away from you this way, okay? So what, no, you do, so yeah, just a little bit small wheel away from you and then advance it, okay? You passed it, so you need to come back, okay? And you have to somehow dip in there now, go in. And sometimes these chronic pancreatitis patients, it's a difficult because the anatomy changes a little bit. हाँ, ठीक है.
उसके एक
Right
एंड से लेके दूसरे एंड तक
नहीं ज़्यादा पुश नहीं करें ना इसको,
एक end से
क्योंकि then you will go beyond that. So here just use the wheels,
या
okay? Just suction.
थोड़ा सक्शन करें।
हाँ जी बिल्कुल. Inflate करें उसको.
नहीं अगर आपका 5 सेंटीमीटर लेशन है तो you need all the way to क्योंकि आपका जो maximum yield है
Inflate, ठीक है? उसके बगैर नहीं जाना. Inflation नहीं है तो नहीं जाना. You don't know where you are going. Endoscopically, you need to know where you are going. Okay. So if you were going there blindly, you have no idea where you are going. Okay. And you are not even close to that. Okay. Good. वो आपको नज़र आ रहा है, ठीक है? Okay. नहीं, यहाँ पे रुक जाएं, क्योंकि अगर आप पुश करेंगे तो उसको bypass कर देंगे, ठीक है? And big wheel away from you. Big wheel a little bit more away from you. Small wheel away from you too. And now gently advance. अब फिर वो वापस आ जाए. Come back a little bit. Come back. Right there, ठीक है? हाँ, चलो. So whenever you don't see anything, again, the most important thing you do is come back. ठीक है? अब यहीं पे, ठीक है? Just no, don't move. Big wheel away from you, and small wheel away from you. Away is away.
Okay.
Towards is towards. Okay. Away from you, and now gently. Okay. Now gently advance. There you go. Gently advance. Okay. Gently advance. And now rotate the scope a little bit to the left, to the right, sorry. Okay.
अच्छा इसकी बात करते हैं आप duodenal gap की.
But you are still hung up in the pylorus. You are not in the duodenum, even though you see it, but you are hung up in the pylorus. So you need to get yourself free of the pylorus. Okay.
So do I need to push it?
No, if pushing you, if it's not moving around, then you don't want to force it. What you do is you rotate a little bit to the right and pull the scope back a little bit. That might, and move the wheel away from you maybe. That might help. Looks like a compression there, huh?
Yeah. ये बल
उसमें
जाएगा
टिश्यू
तो
था या नेक्रोसिस था? Okay.
अब चला गया ना. अब
I
वो
think so.
हुआ है आराम से.
Okay.
Yeah.
So where is the opening of the duodenum? I mean duodenal apex.
मतलब आप इसकी
वो देखें ना, हाँ वो देखे बगैर तो पुश करेंगे तो आप पेरिटोनियम में पहुंच जाएंगे.
वो साइड पे.
ठीक है? Where?
At 12-11 o'clock.
I'm not sure. I think it is there, but what is this? Shouldn't be like that, right? Pull it back a little bit. Pull it back a little bit. No, pull it back a little bit. It's right here. So that's just a groove. Okay. Or maybe this is just a groove going here. एक मिनट दिखाएं जरा.
इधर
Okay,
भी
चल.
वो भी है.
एक
दोनों
मिनट.
साइड्स पे.
खालिद कैन यू टेल कि क्या डिफिकल्टी क्या है यहाँ पे?
अभी मैं बताऊंगा. पहले I couldn't tell what the difficulty is.
आज ये डिफिकल्टी थी.
So there is a little bit compression there, and I think it's all because of the pancreatitis. You see that?
Yes, we can see that.
Yeah. So it's all because of the pancreatitis. मैंने बिल्कुल push नहीं किया. I just hooked up, and I'm just pulling my scope back. The whole time I was pulling the scope back. When I hooked it, and I know where to hook it, move the wheel a little bit, and then got into the second part. So staying into the first part is not going to be easy in this one. And let me just take a quick look
So
here.
यहाँ पे किए बगैर यू टर्न
Yeah, this is different.
ठीक है
Yeah, that would have been a different, yeah. So this is the totally different case scenario. So every case, every scenario, you have to adjust accordingly. Okay. So here, I had a little bit. It's a lot of swelling, lot of edema there. I think it's this chronic pancreatitis or a mass compressing on the duodenum, leading to stenosis. I got through that, and now what I did is, I'm in the second part of the duodenum. My goal is to find the aorta. So the only thing I did is rotate right or left, and that I see the aorta right there. From here, look at my scope. Aorta right here. I'm not using my right hand, okay? To a little bit to the left rotation. You see the IVC,
yeah
okay? Further left rotation.
right kidney
It's gonna be kidney. I don't wanna fall back. So what I'll do is I'm gonna stay in there. It's right. There's some structure right here, but I will stay focused here because it's edema and stenosis. I don't need to experiment too much. So right there, I'm at the aorta. From there, I'm gonna hold my scope with my right hand, pull it back, let the aorta kind of align like this. Okay. From there, I will rotate a little bit to the right to see if I find pancreas. So here,
this is all pain
no, this is no pancreas whatsoever. This is all retroperitoneum. Pancreas is here. Okay, so right here, this is you see the aorta right there. I will pull the scope back, and that would take me to the pancreas. You see the pancreas now? This is all that mass and pancreas right here. Okay. So sometimes you have to pull it back, and it's all calcification all around. This is all inflammatory mass. Okay, this is all necrosis and inflammation there. I can't see anything there because it's a lining of calcification there. So I'll pull back a little bit. You see, this is the area, the neck area, what they're calling a mass. I'm surprised they didn't see the stones on CT scan. Did they mention about that? Did I miss that?
They mentioned lots of calcification.
Oh, they did. Okay.
Yeah.
Okay. So this is what they're talking about mass. You guys can appreciate that, right? This is all the calcification. So I pulled the scope back to take a look at the neck. So even though I'm still in duodenum, but this is that neck area which I was concerned about. I think this is and I fell back now. So I'm back into the stomach or at the pylorus. I'm sitting right there. This is, you remember, this is what I did a FNA of. Okay, so here, yeah, I'm back into the stomach. I'm gonna go, this is all chronic pancreatitis, extensive chronic pancreatitis with acute changes. Okay. So one more thing, now I'm not gonna go into the...
Khalid, you said acute change. What acute change is there?
These are necrosis and so what you look for acute changes is like how much edema is there, okay? And edema is gonna give a rough surface around the pancreas. It's like what we call a speculation. It's not speculation, it's a speculation. S-P-I-C-U, speculations. And let me show you the speculations. And that's those are the findings which tell you that there is a acute changes. Okay, right here. Yeah, okay. Acute on chronic. So, can you appreciate these linings there? Small ones. Here, here. Actual boundary of that necrosis is here, but you can see this roughness at the surface going into the fat. And you see a necrosis here. This is all edema inside the pancreas.
Khalid, you can appreciate the necrosis. Speculations, I don't know, how do you differentiate from...
Here, this one, this edema in there, into the wall, here. This one, this roughness, right here, right here, right here. This is all, and this necrosis with some preserved, maybe a little bit preserved parenchyma, but with edema All these are features of acute pancreatitis.
These are basically
So there is a lot of inflammation here too, in the duodenal wall, and that also is all a feature of acute pancreatitis. So this acute and chronic calcific
Khalid, can you
pancreatitis.
measure the duodenal wall, please?
Ji, bilkul. So this is a little tangential image. This is muscularis. You see it's kind of swollen. So I think I'm going to pick somewhere in the middle, and it's probably up to here. It's 7 millimeter here. And I'm compressing that. And duodenal wall, normal, how much that should be?
4.
I didn't hear that.
जी बताइए कितनी?
And anybody?
So
4 millimeter? So duodenum is the thinnest part. Duodenum and cecum, that's the thinnest part in the GI tract. And usually it's between 2 and 3 millimeter. Okay. Yeah. So 4 millimeter is towards the other side. And here, other thing which indicates it's edema and acute changes is you have no differentiation of wall layers at all. All that is swollen with the water and edema. So that also indicates ongoing acute changes.
So जो इतने extensive collaterals हैं खालिद भाई,
जी.
ये सारा कोई vessel thrombose है या फिर compression हुई हुई है?
It could be either. I did not take a look at the vessels. हाँ जी, मैं और लेते हैं. हाँ जी, मैं मुझे दो ज़रा. नीडल.
अरे खालिद काफ़ी ज़्यादा उसमें वेरिकोसिटीज हैं.
जी जी बिल्कुल.
क्या पोर्टल वेन थ्रोम्बोसिस का क्या एक्सटेंट क्या है?
I didn't take a look at it honestly yet. I did not take a look at the portal vein clearly yet, but I will take a look in just a second.
खालिद भाई आपने बोला था नॉब उधर होना चाहिए, ऐसे कहा था.
जब आप देखते नहीं हो ना तो फिर यही होता है. I can work
खालिद भाई
both
की
ways.
बात हो रही थी नॉब्स की, मेरी बात नहीं हो रही. ओ जी दिन का मुबारक है सारा पूरा.
So here it's a lot of necrosis. So I may change my rule and may go 5 or 6 times in there. So I need some viable cells, and I may not be able to get any viable cells, to be honest with you. But this should have a cells in there. I can feel what I got in there. So with the core needle, you have this tactile sensation. When the tissue gets in there, it looks like, it's not a very smooth movement, the feel you get. It's like crackly a little bit. I don't know what would be the best way. Crackling a little bit, I should say. Okay. Hi. Let me take a quick look at the portal vein और फिर मैं आपको scope देता हूँ. So it was really hard to take a look at the portal vein from the stomach. I couldn't. There's so much calcification. I'm going to try that again. And here, right now, you look at that. You see that? Look, all that is the port. I don't see even a flow in that area. This is a portal vein. You see all the big thrombus there. I'm going to keep rotating it to the right. Keep rotating. It's going through the collaterals. There is no flow through the portal vein here. I don't see, and this is completely thrombosed here in this area. And actually, looks like SMV is thrombosed as well, going down there. Splenic is in this area. I don't see a flow yet on that, but it might have a flow on the other side. Oh, there it is. You see it right there. Yeah. So there is a flow right here in the splenic, but it kind of, this is quite a bit of gain. That was not a flow. So then it goes into the collateral around the portal vein right here. So right there, collateral, going into the splenic right there.
SMV दिखाएंगे मुझे?
Okay. SMV. Okay, so no, I don't see that. So when you see a splenic, you see a portal, this is supposed to be SMV. So it's completely blocked by, thrombosed by the clot. You guys can appreciate that, right? Everybody?
Yes, we can appreciate that. That's very nice.
Okay.
Excellent illustration.
Okay. So here there are other collaterals all around in that area too. Let's see if I can see that from the stomach as well. Okay. So what I'm going to do is I will find my pancreas again. Okay, I'm at the liver now. I think I came back a little bit too much. So right now, after doing so many of these EUSs, thousands of those, I teach this way. I don't do this way most of the time, okay? I just go to the structure, like if I'm at the G junction, what I would do is I find the body of the pancreas and then take a look at the celiac axis and SMA. I don't go from celiac to. But the teaching has to be, and in the beginning, you have to go with your landmarks. Otherwise, you cannot identify that. So here, I'm right at the pancreatic body, and I'm going to try to show you at least. Let me take the arrow off. So this is all that portal vein confluence. But I don't see, this is all that clot in the portal vein right here, which we were looking from the other end. But I can't even follow any lumen there. Oh, there it is. You see the upper part there a little bit, and but that's all clot in there. So there are a lot of collaterals, and look at the amount of collaterals there. Okay. So you see that batter actually from the duodenal bulb. Okay. और ले लें tissue? Enough? Okay. बनाए slides उन्होंने? Okay. Slides पे देखो कि viable cells हैं या नहीं हैं. ठीक है. अब आप आ जाएं. तो D2 में नहीं जाना. क्योंकि it's really very tricky that area. So we don't want to cause any damage. तो आप duodenal bulb में चले जाएं. ठीक है. क्योंकि वो उसमें मैं stomach में. Okay. So I'm going to take a quick look at the slide, and I'll be back in just 1 minute. हाँ जी, क्या है? Viable tissue है? क्या गंदा वाला है या अच्छा वाला है? हाँ? क्या उससे कैंसर लग रहा है? हाँ, ये तो कैंसर है मेरे भाई. Oh, there's a lot of necrosis. I wish malignant है ये. Lot of necrosis. लेकिन वो जो तुमने cells मुझे दिखाए हैं ना, they are real. वो जो ना मेरा ख्याल है कि कैंसर है उसमें. और कोई ग्रुप है या बस यही है? नहीं, उनमें थे सेल्स? हाँ, सही है. वालेकुम अस्सलाम. Unfortunately, I think it's a cancer in there. There's so there are a lot of necrosis.
So possibly that's the reason that we have portal vein thrombosis as well.
Yeah, and portal vein thrombosis can happen with that bad of pancreatitis as well. But yes, I think it's a cancer with the insetting of a chronic pancreatitis. Like these slides, you guys somebody need to take if you are interested, take a look at those. There are like a lot of necrosis you see, and then you see a group of viable cells which look like a tumor cells, and then you see a lot of necrosis which also stain pink and pinkish bluish. So yes, collaterals. So I think there is a cancer on that, unfortunately.
I'm at D1.
Okay,
ठीक है.
जी बिल्कुल.
बाकी सारा कोलेट्रल नजर आ रहा है. अब मुझे इधर से
अभी इधर असल में प्रॉब्लम ये है कि बहुत सारा कुछ नज़र नहीं आता. हाँ, नज़र नहीं आएगा, लेकिन बट यू नीड टू रोटेट इट टू द राइट. ये सारा वो एरिया ऑफ द जो है ना, एंड देयर आर सो मेनी कोलैटरल्स अराउंड दैट. ठीक है, तो चलते जाएं आप टू द राइट, and you're looking at the gallbladder actually right now, and you see a liver right there, gallbladder here.
So abhi chalte jana us taraf?
No, gallbladder, if you are looking at the gallbladder there, that means you need to really rotate up quite a bit to the right to get to the pancreas. Okay, and you need to pull the scope back, and you start seeing that edema there of that.
Oh,
yes,
yes,
you
yes.
start seeing that now.
सारा
That's
जो
it.
fat है वो that is
Yes,
blurred actually.
blurred,
Yeah,
and
that is blurred.
and everything
Oh
is
my God,
blurred
so
there.
much of collateral.
Yeah,
So
so
I
much
need to
collateral.
pull it back a little bit more.
और क्योंकि when there is that much inflammation, collaterals, that changes the anatomy to some extent. Then you have to go with your really landmarks. यहाँ the
Do I
gallbladder.
need to pull it back further?
No, I think you may be too back now. You're looking at the gallbladder from a
Yeah.
different angle right now. So you're looking that
So I need
at
to
that
push
from
the
that.
scope
No, no,
further?
you all never push the scope. If you are seeing the if you think you are back into the stomach, you need to do an endoscopic view.
Okay.
ठीक है?
So I am back in the stomach.
हाँ, तो इसको inflate करेंगे. So when you saw the gallbladder second time, it appeared from different area.
Yeah.
That means you're looking at it from the different station.
Okay.
So then you need to adjust yourself and take a look at with the endoscopic view. नहीं हमें नहीं चाहिए था, ये उनको चाहिए था, वो देखना चाह रहे थे रूम में. Yeah, you look at that portal vein and look at those collaterals. तो ये bile duct है, ठीक है ना ऊपर, ठीक है. You can follow the bile duct towards the head area. चल ठीक है, चलते जाएं, follow करें, and hold on right there. So
Yeah, this is bile
ठीक है,
duct.
bile duct there, and that was actually a cystic duct. So if you still are far away from the pancreas actual. So this is a portion of it right here, this one.
Yeah.
So इसको look. Keep going to the right. No, keep going to the right. It may not be possible, honestly. Okay, it's all because of so much distortion of the duodenal bulb by that mass and everything. Okay.
तो अभी फिर इधर से यूँ ही जाना
हाँ,
है.
ये बिल्कुल. And it may not happen.
अयोटा आना शुरू हो गई मुझे.
You got the cross-sectional view of the duct with the duct.
Yeah, it
हाँ ये
is.
तो आ रही है duct.
Beautiful view.
Yeah, लेकिन इसको ट्रेस नहीं ना हो रहा उधर इस
So
तरफ.
you trace.
So much distortion there.
और फिर तरीका क्या है? ये तो
मैं
move
तो
तो
दिखा
कर रहा है
था.
पूरा स्कोप ये देखो.
मूव नहीं
लेकिन-
कर रहा सही तरह. आपका हाथ बहुत ज़्यादा मूव कर रहा है.
हाँ.
स्कोप के नंबर मूव नहीं कर रहे हैं.
अब-
एक मिनट ठहरे,
हाँ.
थोड़ा पीछे हो गए, ठीक
पीछे,
है. वहाँ पे ठहरे. इट शुड मूव लाइक दिस. ठीक है.
So I should
तो आपकी
move it
पूरी
from here.
मूवमेंट जो है ना वो नहीं ट्रांसमिट हो रही, और उसकी वजह ये थी.
ठीक है. अब आप स्कोप अगर
स्कोप
सीधा- ओके.
ओके. एक मिनट ज़रा दिखाएं, मैं देखूं और कुछ नज़र आएगा इसमें या नहीं. वो एनाटमी मसला है या ऑपरेटर मसला है.
You done with that?
Yeah, it's a cancer. This is all head of the pancreas. ये देख रहे हैं, ठीक है.
अच्छा कोई डेफिनेशन नहीं है.
कोई definition
कोई
नहीं.
definition
There's
नहीं है.
no
All gone.
definition whatsoever. Right there. It's all necrosis, edema, inflammation. पूरा जो है ना एरिया ही जो है ना, ये देखें ना, अब ये सारा pancreas का है वो. आपको क्लासिफिकेशन नज़र आ रही है. ये है head of the pancreas, ठीक है. और जो है ना वो bile duct वहाँ पे थी, ठीक है. पोर्टल वेन का थ्रोम्बोसिस यहाँ पे है, एंड दिस इज़ द हेड ऑफ द पैंक्रियास. तो मैंने सिर्फ जो है ना पोर्टल वेन जहाँ पे कॉन्फ्लुएंस है ना, उस पे स्कोप को देखें पोजीशन, और उसको मैंने सिर्फ थोड़ा सा राइट की तरफ रोटेट किया, कुछ भी नहीं किया. और मेरी स्कोप रोटेशन देखें कितनी हो रही है,
ओके.
ठीक है. एंड व्हाट आई डू इज़ आई ट्राई टू स्टार्ट फ्रॉम हियर, so I have a lot of space for me to do the rotation. If you start from here, you have no space. वो फिर वो पीछे की तरफ देखना पड़ेगा.
फिर इधर से शुरू करना.
हाँ, ये देखें, this is the head area.
सही है.
So you see the calcification and all that necrosis there. So I can see that from the duodenal bulb, head area, but it's look at that. Easy, very like if you are in the right place, it's a very
ये duct
easy.
आ रही है ना ऊपर.
Duct ऊपर and portal vein here. ठीक है, मैं Doppler उसका डालूं. Right here, actually that is right
Duct
there.
भी तो ये.
हाँ,
ये डाले
duct, हाँ. और
Is it
duct,
a duct?
नहीं, it is.
अच्छा,
होता ये है कि कई दफ़ा ना वो पीछे से आ रही होती है,
Okay.
बिल्कुल, ठीक है. तो sometimes that happens. Okay.
अच्छा इसका मतलब है खालिद भाई जब स्कोप बहुत ज़्यादा टॉट हो जाए, you have to move a bit.
You have to move a bit.
पीछे हो जाए.
बिल्कुल.
सही है. अभी यहाँ से आपने मुझे देना, मैं उसको पीछे करके पीछे
ये
होके
देख रहे
करती हूँ। हाँ,
duct?
बहुत ज़्यादा डायलेटेड है।
Duct नज़र आ गई ना?
Yes.
Okay. So there are so many vessels around. They are moving. Sometimes it's a two-dimensional image. You're moving a little bit on one side. You're picking a vessel. You're moving a little bit to the other side. You're picking a duct. So when I'm picking a duct, now I'm going to move. I'm picking up a portal vein. I'm picking up a confluence here. ठीक है? अब यहाँ से I'm just going to follow the duct itself. Actually, there's a cystic duct too, which coming off right there. तो ये जो सारा है, following, lot of collaterals, and ये जो है ना head का area इधर से आना शुरू हो जाता है, ठीक है? चल आ जाए.
ठीक है, यानी इधर से मैं शुरू करूँ।
हाँ, इधर से. If you start from here, when it's laying down on your hand, even further. नहीं, अभी आप क्या देखें ना, आप
अब तो मूव कर, अभी
इधर
और
से.
पीछे होना है,
हाँ,
इधर,
हाँ.
ओके,
Yeah, give yourself space
Okay.
to move, ठीक है?
ठीक.
यहाँ से आपने करना है.
ठीक है,
तो आप चेक करती जाए, नो दूसरे हाथ से पकड़ लें बेशक, ठीक है? चलती जाए, चलती जाए, चलती जाए. Good, excellent.
Specimen biopsy.
ये देखें, आ गया सारा कुछ.
ओके।
So
तो
it's
सिंपल डॉट होना नहीं चाहिए।
हाँ, सिर्फ इसको नहीं, ये जो इसका मकसद जो है वो ये है कि वो हम जो है ना ट्रांसड्यूसर को मूव कर रहे
ठीक
हैं,
है,
ओके? ठीक है?
सही।
चल,
अच्छा, ये गॉल ब्लैडर है ना?
ये काउंट रहा
तो इसका वाला पीछे आ गया।
हाँ, वो दे. Okay. और sometimes happens there is not much space actually in the duodenal bulb, क्योंकि अडीमा की वजह से वो देखे ना कि बिल्कुल स्पेस नहीं है वहाँ पे. आपको तो ये भी नहीं रियली पता लग रहा कि वो एक्चुअली ल्यूमन है कहाँ पे, ठीक है? तो सो मच अडीमा पे, ठीक है? अब चले मीडिया स्टाइन करते हैं, आ जाओ वापस. ओके,
ये एक दफ़ा मैं कर लूँगा।
बिल्कुल कर रहे हैं.
ये हाँ,
ठीक है.
प्रैक्टिस करा रही हूँ कि मेरे से मैं टॉट हो जाता है और इधर से तो जा रहा है ये।
बिल्कुल ठीक है. तो what you do is you look at the duodenal apex, you put your transducer there. देखिए कितने खूबसूरती से वो आ गया, ठीक है ना?
ये तो पैंक्रियास ही आ गया नीचे सारा।
हाँ, ये सारा आ गया ना. तो अब अगर पैंक्रियास आपके पास यहाँ पे आ गया है तो आप इसको थोड़ा रोटेट करें इस तरफ. अगर नहीं आता तो जेंटली से पुश करें. राइट,
ये आ रही है टोटल।
ठीक है. हाँ, तो जब ये आती है ना तो फिर आप थोड़ा सा पीछे मूव हो जाए. Can you guys see the
Yes, we can see
specimen?
that.
Specimen, right?
Yes, we can
So,
see the
yeah.
specimen.
So these are all the cells there, which is viable tissue, and around those is quite a bit of necrosis. Thank you.
ओके, ये अब आ गया, ठीक है ना? ये आ गया ना?
हाँ, बिल्कुल आ गया.
लेकिन मैं आपको ये बताना चाह रही हूँ कि अभी मेरा स्कोप देखें तो पीछे हो, स्कोप स्ट्रेट है ना, और अब ये मूव कर रहा है।
हाँ, एब्सोल्युटली. वो देखें ना ब्रेन कैसे मूव कर रहे हैं, बिल्कुल 1-to-1 मूवमेंट, ठीक है. हाँ,
अच्छा, अभी
तो स्कोप को जितनी स्पेस आप देंगे उतना जो है ना वो आराम से काम करेगी. अगर आप वो
अभी
बंद,
मैं उस पे जाके ना वो
Media
लेफ्ट होगा, वो देख,
ठीक
यहाँ
है.
पे देख लेना आप लोग।
एंडोस्कोपिकली दिखा, ठीक है. हाँ, वही है, इधर से भी देख लें, उधर से भी देख लें, ठीक
अब
ठीक है.
इसको ये है IVC,
IVC,
ये एक
हाँ, ठीक है. थोड़ा सा आप पुश करें, थोड़ा सा पुश, बिग व्हील टुवर्ड्स यू, थोड़ा सा अंदर जाए, ठीक है. एंड अगर हंग अप हो जाए ना तो पुश नहीं करना है, क्योंकि दैट वुड कॉज द परफोरेशन, ठीक है. तो यहाँ से आप रोटेट करें, रोटेट 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 रोटेट. अब देखो ना आपकी रोटेशन नहीं हो रही बिकॉज यू आर सो क्लोज. तो थोड़ा सा पीछे हो जाए, कोई मसला नहीं, ठीक है. हाँ, ठीक है. जितनी देर में स्कोप स्ट्रेट होगी, हाँ, चलते जाए, ठीक. IVC, चलते जाए, चलते जाए, चलते जाए, चलते जाए, चलते जाए. तो और big wheel towards you a little bit and keep going, keep going, keep going, keep going, keep going. There you go. ठीक है. तो अब जब एओर्टा आ जाए तो फिर उसको आपने जाने नहीं देना कहीं.
ठीक है, वो चली गई आगे।
इट्स ओके. तो या इसको थोड़ा सा रोटेट करें लेफ्ट की तरफ, लेफ्ट लेफ्ट लेफ्ट. ओके, नहीं बल्कि राइट जाएं ज़रा, राइट जाएं, राइट. ओके, अब थोड़ा सा व्हील को रिलीज़ करें. वो हो ये रहा है कि योर व्हील इज़ वे टू मच ऑफ. ओके, ये देखें फिर आ गया. यू जस्ट नीडेड टू रिलीज द व्हील और फिर वो जो है ना बिहेव करना शुरू कर देता है, ठीक है. अब इसको फॉलो
अब
करें.
इसको यहाँ से मैं आगे हो जाऊँ ना?
हाँ, बिल्कुल. रोटेट करें लेफ्ट की तरफ, लेफ्ट की तरफ, लेफ्ट की तरफ, लेफ्ट रोटेशन. यू सी दैट? Okay. Okay, I'm going to follow that, follow that, follow that. All takes you straight to the pancreas. गुड जॉब, एक्सेलेंट।
अच्छा इधर से मुझे एक मिनट, मैंने आपसे वो सीखना है कि यहाँ से मैंने आप उधर जाना है, ठीक है। अब आपने मुझे बताया था कि इसको सेंटर में रखना है पेंक्रियास को,
बिल्कुल,
जिससे कि
और
नीचे
ये पीछे
और
होना
इसको
है,
पीछे होना है,
बिल्कुल,
ज़रूरी
ठीक
है काम।
हाँ,
और उसके बाद अब ये आ रहा है सारा
बिल्कुल आ
पेंक्रियास,
रहा है, बिल्कुल आ रहा
ये
है।
भी
अब
आ
उधर
रहा
जा रहा है, ठीक है। तो फिर
तो मैं
आपने
इसको
स्कोप को पुश करना है थोड़ा सा,
ओके
स्कोप को उधर जाएगा तो पुश करना है, इधर जाएगा तो पुल करना है,
ओके
ठीक है।
ठीक है।
तो
अब
वो
इधर
ये जो है
मैंने
ना
इसको-
आपको मूवमेंट और प्रैक्टिस से पता लगेगा, ठीक है। चलते और ये देयर यू गो, राइट ऑल द वे प्रीटी मच टुवर्ड्स द टेल
ये
एरिया,
आ रहा है ना ऊपर जो पेंक्रियाटिक टिश्यू ये आ रहा है।
पैंक्रियाटिक टिश्यू के टेल का, ठीक है। अगर आप थोड़ा सा पुल करो इसको तो ये स्प्लीन है, इधर
Where is this vein?
ये भी आपका पैंक्रियास राइट,
अच्छा खालिद भाई ये एक मिनट, ये जिस तरह आप इतना बड़ा पेंक्रियास
राइट, हाँ जी।
अच्छा अब इसको मैंने अगर आप कह रहे सेंटर में रखना है ना, तो अब यहाँ से मैं इसको मूव कर रही हूँ, अब ये अगर उधर जाता है तो इसको मैंने
पुश करना है स्कोप
अच्छा
को,
पुश करना है,
क्या?
push
ये
किया,
देखा,
ओके
ठीक है।
उसके बाद फिर
करते
अब
जाए
push करते
उसी जगह, नहीं पुश
हाँ।
नहीं करना, एक दफ़ा आ जाए वापस
हाँ।
तो फिर आपने रोटेशन शुरू कर देनी है,
अच्छा ठीक
ठीक है। पुश या पुल उसको जो है ना ट्रांसड्यूसर के
ओके।
नीचे लाने के लिए,
तो
ठीक।
अभी ये निकला गायब हुआ तो उसके बाद फिर मैं इसको करूँ,
हाँ, अगर देखा अब इस तरफ जा रहा है
ठीक है
तो इसका मतलब है स्कोप पुल करनी है,
ठीक
ठीक
है।
है। और जब एक दफ़ा वो नीचे आ जाए
हाँ।
तो फिर सिर्फ रोटेशन करनी है, ठीक है। रोटेशन अगर नहीं आता तो फिर आगे या पीछे करें, बिग व्हील टुवर्ड्स यू लिटिल बिट, ये देखें
थोड़ा सा ये।
ये आ गया,
ओह,
हाँ
end
जी,
पे आ गया,
एंड
ठीक
पे,
है। ओके,
क्योंकि
ये
बिग
पेन
व्हील आप
नज़र आ रही है,
और नीचे
पेन पे
स्प्लीन,
वो स्पिन पहुंच गई है। ठीक है
ठीक
तो
है।
यहाँ से भी हम लोग कर सकते
हाँ,
हैं।
यहाँ से भी नहीं, और लेकिन वो क्योंकि आप वो पुल नहीं कर रही थी व्हील को,
अच्छा
ठीक है। तो ये सारी मूवमेंट्स जो है ना सिर्फ देयर आर सो मैनी कोऑर्डिनेटिंग मूवमेंट्स, इज राइट लेफ्ट टॉर्क, move the scope in, move the scope out, use the wheels and use the torque, wrist, use your shoulders. It's a combination of all those movements, ठीक है। चलो
अभी ये सारा पेंक्रियास आ रहा है ना?
हाँ, सारी इन्फ्लेमेशन बिल्कुल।
अभी इसको फिर मैं यहाँ से मूव करती हूँ। किडनी को अब करके ये किडनी वाली चीज़ होनी चाहिए। नहीं, ये बंद है। ये वेसल आना शुरू हो
सारी वैसेल्स आनी शुरू हो गई, ठीक है। चलें ठीक है, आप चलो कर लें क्योंकि मैं लेक्चर भी करना है, ठीक है।
अब मैं वापस इसको अच्छा यहाँ पे
30
कितना है
30 30
30 पे आ गया।
30 ओके ओके। स्कोप को उसी तरह न्यूट्रल सक्शन, देखा न्यूट्रल स्कोप,
ना? ठीक है
ठीक है। और 30 के करीब, और फिर ज़्यादा नहीं करना ना,
ठीक है
बिग व्हील
Okay.
टुवर्ड्स यू, टू मच एयर इन द बलून, दैट्स व्हाई, ठीक है। आपके अप्रॉक्सीमेशन थोड़ा वाटर डाल लें उसमें बलून में, बलून इज ब्रोकन,
अब ठीक है पानी
ना नहीं कुछ भी नज़र नहीं आ रहा, तो ठीक कैसे
पानी
हो
तो
सकता
डाल रही
है।
हूँ मैं।
ओके, तो फिर उसको आप सक्शन करें,
अब आ रहा है ओके
बिग व्हील टुवर्ड्स यू,
थोड़ा सा ना बस इतना कि मुझे इस पर नज़र आ जाए।
ठीक है। लेफ्ट एट्रियम दिया,
जी
ठीक है। इसको पुल करें वापस यहाँ पे,
डू आई नीड टू पुल
no, you stay there, pull a little, big wheel towards you a little bit, just a little bit
ओके
towards you, little bit, ठीक है।
तो कितनी देर में खुशी और रह गया सर?
2 मिनट का, आप उधर चले जाएं आप लोग, क्या हुआ,
सर ये लंबा होता जा रहा है।
2 मिनट का रह गया, हाँ।
ठीक है
ये पल्मोनरी आर्टरी
जी
और ये लेफ्ट एट्रियम सबक्राइना,
ठीक है
ठीक है। और इधर से आपने स्कोप को नीचे के देखना है,
लेके जाना?
नहीं नीचे नहीं लेके जाना, रोटेट करना है, ओके।
रोटेट करना
हाँ
सही है
ठीक है, ये आ गया, एओर्टा आ गया,
ओके
ओके। वापस
जहाँ
बिग व्हील
खत्म
टुवर्ड्स
हो
यू,
रही है।
बिग व्हील टुवर्ड्स यू अ लिटिल बिट, हाफ वे एंड व्हील्स फेसिंग द पेशेंट, राइट देयर, बिग व्हील टुवर्ड्स यू अ लिटिल बिट, एपी विंडो। चलें अब निकालते हैं वो सीधे लंबा। थैंक यू मेरा भाई।
Okay, 1 hour 55 minutes.
1 hour 55 minutes.
Yeah.
Wow.